please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
So we have case reports, and Juliana Mortensen has outdone herself. It's amazing. Jerry Pollack just said in his slides. Diana Cross just emailed me and said that her research is covering her living room floor, and she'll have it in soon. My case report with Jennifer from TIVIC about the Vegas and our HRV data. That's about done. Yeah, it's pretty exciting. It's just all coming up. I got a note from Christy Hughes saying, don't panic. I've got my slides ready. I don't expect David Musnick until Sunday if I'm lucky. And then Juliana Mortensen has outdone herself. Every time I think she can't possibly tell us anything different, it's just magic. I want to download her brain. And then Jennifer Ernst has the HRV data. So I did the Vegas part, and she's doing the HRV data on the Vegas protocol. Like, we have data. Not only do we have data, we have a patent. I'm so excited. It's so fun. And then who else? Jerry Pollack has got his in. Diana Cross is coming up from Australia. And I got an email from her saying that you can't actually see her living room floor because she's got her research papers spread all over the floor. And then she's going to get her slides done. That's what she said. And it's like, what? It's okay.
Mine is,
and she's getting ready to write. And you're what?
Okay, thank you. Slides are coming, and I was almost done. And then Dr. Musnick was like, can you focus? Can you do me a favor? And I was like, yes, I will do anything for you, Dr. Musnick. And he says, could you focus on the hip? I am seeing so many hip people lately. I'm like, I would love to take a deep dive onto hip stuff. So my presentation morphed a little bit to do hip and pelvis, and it has gone through so many cool phases of anatomy. I got these amazing anatomy slides, nerve, lymph, different pathologies. I am in love with this presentation.
Oh, goody.
So
That's the best.
What I was waiting for was this case report that I'm working with, this amazing female who had a disc surgery gone not as well as they had hoped. And the nerve pain experience that the surgeon is saying, it's never going to come back. It's never going to change. You're going to have this for the rest of your life. It's irreversible. When I can reverse it,
whatever,
in 25 minutes and take before and after pictures and document it with a magic marker and a pinwheel and measuring girth around an atrophied calf muscle. So I'm just, Kevin, it's coming. I am just putting all that data into the last 20 slides because I think the case studies, while we don't have enough published papers, the case studies that can show objective findings, I think to me are just so inspirational. That's why I love the advanced meetings, is just to see that data.
We had a meeting with David Suzuki and his team this morning, and they're doing the final stages of getting our CE mark as a class 2 medical device in Europe, Asia, everywhere. And the thing they want is between 50 and 100 aftermarket data. I can't remember what the acronym is, but it was aftermarket data. And it's, you want me to do case for different body parts. So right now we've got 200 cases published on low back pain. We've got a paper on neck pain with 100. And it's like, they want different body parts. And I said, does it have to be published? And they said, no. So we have all the certification case reports We have every case report that's ever been presented at a symposium or an advanced for the last 22 years. And I said, so they're going to send us a spreadsheet and everybody's case report that says shoulder, frozen shoulder, great. Goes, and so we've got a Excel sheet, and at the end of it, we will have a tally of all of the different pain applications, including the one that you just did, which is, oh, that's just nerve pain. That's not that hard. And so there you go.
I think it's just so exciting because like any clinician can do it. And it's not when we have the FSM certification tract that you can go through and it's, oh, I need to have 10 case reports. I'm like, that is so easy because hopefully everybody's charting and your SOAP notes can turn into a case report very easily. And
1 week.
and if you're a nerd like me, it's just so interesting to see the SOAP note, go into a case report, and to review your findings. And every time I'm going through their subjective complaints, seeing that pain score go down, seeing range of motion improve, that's just validation. That just feels good to review that.
And I had to explain to somebody who's going through the certification process, it's like, why do we have to do case reports? And it's number one, the purpose is for us to collect data, but the purpose is to get you used to writing up case reports so publishing a case report won't be so terrifying.
Yeah.
And we need you to ascend to the place where you're willing to able to publish a case report. But
Yes.
as it turns out, there is this wonderful use that will get us a CE mark, and it's aftermarket data, which is something the FDA likes anyway.
Can you explain aftermarket, what that?
It means after you start marketing this device and you're using it, getting a 510K, you can make a gadget in your garage, pay $250,000 and get a 510K. So a device with a 510K is like no big deal. A CE mark, David Suzuki, the person that makes our devices, the CE mark is for the device. It takes a notified body. He has been working on this for 4 years, and we are at least $250,000 to $300,000 into it to get a class 2. We have a class 1, which is over-the-counter pain stuff. To get a class 2 medical device CE mark has taken them 4 years, and aftermarket data is, okay, you have this device, you had to do this to get it on the market, but did it work for 2 people, 5 people? They want between 50 and 100 cases for different body parts. So neck, shoulder, knees, hips, nerve pain, arm, low back pain. We have a published paper from India on 237 patients. So for every body part that we have cases for, up to 100 of them, that can be included in the claims we're allowed to make in print for the device. FSM, that's a whole different project. The device has to have support before you can make claims for it. So that's why when you look up a device on the internet, it's all fuzzy. There's no actual sentences. There's words, we make you feel better and be that. So Suzuki he described himself this morning as being obsessed with getting this done. He's Japanese, and I don't know if it's a cultural thing, but he has got the bit in his teeth and he is not letting go of this. So we will have a class 2 CE mark for Europe and Asia by the end of the year, I would guess, assuming we can get this spreadsheet done. I may have to take a week out of the clinic to just go back through all the cases I've got. But
Yeah.
so there we
That's exciting. That's very exciting. The devices are always a hot topic, and why do we use the devices that we do? And so what you had just went through just talks about the validity of the device and the safety of the devices and how difficult it is to have a device that people can feel comfortable and safe using, and you want to feel confident in that.
the quality standards for US made devices, shall we say, are just different than quality standards for devices made in China. So we'll just leave it at that. The coolest case yesterday,
Tell me.
lane change.
Yeah.
Um,
The whole freeway ahead
patient
of us.
had, yes, and I'll let you get to your list, and we've already got questions, but this was so cool. Patient had a right knee replaced 2 years ago, and it went fine. She had her left knee replaced in December, and it has been red and swollen, and they thought it was infected, so they just are on antibiotics, but the knee is still redder than it should be 10 weeks after surgery. And I said, can you look up or ask what metal was used? And her right knee was titanium. Her left knee is chromium cobalt. So just so everybody knows, surgical grade titanium, if you Google it, has an allergy incidence of 0.6%. Chromium cobalt has between 3 and 6%, and one study showed as high as 20%. And stainless has between 10 and 27%, 10 and 20%. Somebody can check me out on that. But surgical grade titanium is the only thing you should use. And in this case, there's a pretty good chance that this lady has dissimilar metals in her body, which is going to drive her immune system crazy. Nobody is going to do a revision of a knee replacement because of a metals allergy. The infection is gone, but her knee was hot and the incision was red, maybe a centimeter on either side. And so I wrapped her knee above and below, and I ran the frequency for metallic toxin in the periosteum, the bone marrow, the skin, and the bursa. The swelling went down, the redness went down, and the knee was less swollen, so the range of motion was better because she wanted me to treat for scar tissue. And so I'm not sure scarring is our problem. It is available in my chart usually, but every patient you have that heads for a joint replacement, whether it's an ankle, knee, hip, whatever, shoulder, make sure they insist that they are comfortable insisting on surgical grade titanium, especially patients with leaky gut or IBS or food allergies or any sort of sensitivities at all. Titanium is your friend, but so 16 is the frequency for metallic toxin. I don't know if chromium is toxic, but there we go. So that was my story from yesterday.
And does it matter, like, in what state or country do they use different metal alloys, or do you know what I mean? Like, where are the implants or the joints sourced from?
They all have to be FDA approved, at least so far. They're almost all, as far as I know, US made. When my surgeon went to repair my left shoulder, I asked him, he said, we're going to do your shoulder this afternoon. And I said, what metal are you using? He said, stainless. It's less expensive. It's ubiquitous. Lots of things are made of stainless. I said, you can't. I'm allergic to it. What? Yeah, it's got nickel in it is the problem child. The allergy reaction to nickel by itself is about 70%. It's huge. So it's the nickel in the stainless that's a problem. I said, you can't use stainless. And he went, I said, here, wait. So I called Mary Ellen Chalmers, who's also lecturing, by the way. And I said, Mary Ellen, he wants to put stainless in my shoulder. I broke it. And it's, yeah, I know, but would you talk to him? So I handed him the phone and he made surgeon noises. And then he was quiet for 20 minutes while she talked. And then he hung up the phone and handed it back to me. And I said, so what's up? And he said, I have to find titanium hardware. I've never used titanium hardware before. I have to source it. So he brought in a computer from the nurse's desk and spent 2.5 hours in my room on the computer finding titanium, 3 different sizes, because they don't know till they get in there what size things needs to be. 3 different sizes from Seattle, San Francisco, and Los Angeles, all to be at the hospital by noon so it could be sterilized so he could do the surgery at 3 o'clock the next day.
Wow.
Yeah, it has to be at least in stock locally, and I'm assuming it's made in the US. I don't know the answer to that one.
It reminds me of, you probably don't remember this. I remember it very clearly. This was the phantom gallbladder call that I made
Oh,
to you
yeah.
in my early years of being an FSM practitioner because, and I'm the first to admit when I'm wrong. And so taking the core, it's a lot of information. And I think as a new clinician, you do this weird filtering. You're like, I need this, but I don't need that. Instead of saying, I'm going to take it all, because you're so used to just thinking, I can only affect the fascia or I can only affect the muscle. So when you would start to go into certain things, my brain was like, yeah, whatever. So when I had the patient, and this was a written case report that I did, who had low back pain for a year, that she was going to PT twice a week, every single week, paying cash. So the pain was not really resolving, but it was her low back. It would radiate across the posterior innominate crest, down the lateral part of her leg, and sometimes go medial. So the pain pattern was interesting. Myself being very pelvic centric was looking for a torsion. She had a little bit of an innominate rotation, a little bit of pubic tubercle shear, fixed all of that, but it wouldn't really help. So I saw her for about 3 or 4 treatments. Things weren't getting better. And I still had the birdie in my ear saying, it never not works. Keep looking. And she had her gallbladder taken out 6 years ago. When I asked her, when did the pain start? She said, about 5 years ago. So a year after having the gallbladder removed. That wouldn't have really clicked pre-FSM. I would have not put that together. But when you think about visceral adhesions, the pain started a year after, and I did treat her abdomen for visceral adhesions. However, like you had just mentioned, yeah, there might be scar tissue or adhesions there, but why is there scar tissue or adhesions there? Now, this patient was one of the ones that you pray for as a new clinician who is very sensitive to the current, didn't know what she was feeling, but would just be able to say, oh, this feels amazing, or now the pain is gone, or now it feels icky. So these type of treatments they're like blinded studies because the patient doesn't know what you're doing. So when I thought about when I was going through her file and I saw the MRI report and they talk about these clips that are in place, I thought, I wonder if something has to do with these metal clips in her belly. And then I looked at her and she had no jewelry on whatsoever. And I said, I wonder. And you just have that thought experiment. And I said, I noticed that you never have any jewelry on. And she says, no, I have this ridiculous metal allergy. I can't touch anything. I have to wear 24 karat gold or nothing at all. And I was like, damn, what a problem to have.
Yeah, poor baby.
But then I thought, you know what? There's that thought experiment. So I looked up in the laminate metal allergy or metal toxicity, and I ran it even though I knew she didn't have a gallbladder in the gallbladder because the clip was clipped onto something at once upon a time. And so after 30 seconds, I don't know what you're doing, but it feels amazing. And I took my hands off and I grabbed my phone and said, I'm going to be right back. And that's when I called you. I'm like, I think I'm treating phantom gallbladder pain. And you said, yeah. And now open up your netters and see what's around the gallbladder and treat the small bile duct. And there I had my viscera page open and the pain was completely gone. And it lasted for about 4 days. So I would get her in every 4 days and run this metal toxicity and do some movement. And then we had the conversation of, okay, these clips are not going anywhere. They're staying in your body. So let's get you a CustomCare and put on this program. And then you have a tool to help you with everything. And that's exactly what we did. So she bought a CustomCare. We set up a protocol for her. She ran multiple things, but every 4 days she runs metal toxicity. The pain never came back.
Yeah, and you saved her a fortune. She spent upwards of $2,500 on a CustomCare, and after 2 years of PT,
Yeah.
cash,
Yeah.
it's there are, and this lady already has a CustomCare. So yesterday I put metallic toxin or knee metal, and I said, just run it every day and I'll see you in 2 weeks. It's just, and when you were talking about number one, the little bird, it just never goes away. And when you were talking about the FSM course and all of the different pieces it reminded me of Thanksgiving dinner. Everybody brings a dish, so you've got 12 things and you have a plate this big and it's, oh my. So you pick those and you can digest those, but then there's another 5 or 6 and those look pretty good. And then you go back, and that's what FSM was like. It's like Thanksgiving dinner. You just digest it a little piece at a time and then have a nap and then go back and visit it again.
That is one of the best analogies I can think of. And when you've digested enough and you're ready for the next plate of food, you've got leftovers in the fridge or in the freezer waiting for you. So
Something else walks in.
something else walks in. And I think once you have that case, and for me, it was what I call phantom gallbladder person, she really opened up my mind to the cause. Why, where, when, how. We're so used to, is the pain bright? Is it sharp? Is it in the morning? Is it at night? We're so myopic sometimes in our assessment that the more lateral and even the more posterior you can get with the history, the more information you're going to gather, the more information, the more comprehensive your strategy can be.
And there's these days, the other piece that I would never have thought about 10 or 15 years ago was the patient said, can you do anything about inflammation? Where? Everywhere. I have all this joint stuff. And I said, how long has that been a problem? About 2 or 3 years. I said, well, the way you keep inflammation down is to treat the vagus. Have you ever had COVID? Oh, yeah. I had it, I don't know, 2020, 21. I had it twice. And then I got vaccinated, and then I had it again in 22. And when did all the joint inflammation start? About 3 years ago. I said that would be 22. So the thing I ran on her for her joint pain was treating her vagus for COVID frequencies, and then the blood supply with the virus frequencies, and then the cartilage for inflammation. And I just did that neck to feet because she had everything from her fingers to her elbows to her knees to her toes were inflamed. And the vagus is what turns inflammation down. And 20 years ago, 15 years ago, there wasn't a virus that everybody got that persisted and turned the vagus down. Now there is. So now that's another, like you said, in the back or in the deep recesses, that's a question that always has to get asked.
Yeah. And the more you get used to asking questions, and it's funny, I'll get a new client that will just start talking and giving me, oh, I'm so sorry, this is probably too much information. I'm like, no, there is never too much information. And the fact that you want to mention it means it's really important. And I had somebody said, it just feels so good to have somebody listen to your story. And I said, I know. So I think even that component to what we do is so helpful in the healing journey, is just being there to listen to somebody's story in its entirety, not saying they're crazy, not saying what they're telling you isn't important, because it's so important. And how many times do you get somebody on the table that they've told you you think their life story, and then they're like, oh, did I tell you about that car accident I had 10 years ago? I'm like, no.
Yeah, no. But now that you mention it, it might have something to do with the pain in between your shoulder blades.
Yeah. So, yeah.
I love being us. It's what I think makes FSM practitioners such a special group of people. If you're not willing to do that, and there's some FSM practitioners literally that just give me nightmares because I get patients who say, oh yeah, I went to this FSM guy in whatever state, and he just put sticky pads on me and pushed a button and left the room. I don't know what he did. It didn't help. Oops. But I don't think people that have been trained in the last 8 years, 10 years are like that anymore. I think we have a different group.
And it's funny because I think the question touches on that. And I have a lot to say about the question. The question says, question from a few podcasts ago, both of you mentioned that just hooking up an FSM machine and leaving the room is not good practice. Correct. Because of missing hands-on changes, you track to see, feel the FSM is working. I get that for lots of the treatments, but for things like 124 and 22 for treating leaky gut, 1 hour a day for 5 days, as Dr. Musnick suggests, or lots of the internal stuff like bleeding, scarring from appendectomies, toxic megacolon as well. They use relax and balance, mole, concussion, vagus, even virus ones. I find there's no tactile feedback to monitor, so I just run them as I rest or walk around on, and on others, I hook them up and let them rest. Yes and no. Again, yes, I understand you may not feel smush when you're running virus on somebody. However, there are a lot of subtle changes, and depending on your scope of practice, you may not be able to run something unattended. So there's that whole legality as well. So I'll let you talk and then I'll jump back in again.
Oh, you're spot on. There are patients where it's like 124 and 22 for leaky gut. I don't have to be there for that part, but I spend the time with the patient ahead of time, get my hand on the tummy and say, look, you've got leaky gut. People that have leaky gut, they end up with a CustomCare because I only see them for 5 days. But you could do your attended part and then switch to unattended. Either you move to another room or make sure the patient's cozy with a blanket and a heating pad and a washcloth on the front and back, and you're running SIBO or leaky gut, and it's going to take an hour and a half, and you tell the patient to bring a book. The second question is, I ran leaky gut an hour for 5 days on a friend who has residual GERD and digestive problems after radiation treatment for throat cancer. And he reported that even the first day after that, his stomach felt better and he wanted to do the whole course. Absolutely cool. And the thing I hope you remember is that radiation for throat cancer, where's the vagus nerve go? Comes out behind your ears and then it goes under your jaw and then follows your esophagus down in your stomach. So the other thing to do besides just treating his digestive system, bless you, is to treat 54 and 10 for radiation and scarring in the vagus. And then on a CustomCare or a second machine or whatever, run from around the neck onto the pubic bone, increase secretions in the vagus or concussion to vagus.
Yeah.
Use pads, no brainer.
Hang on, I want to go back before you go to the other question.
Okay, go.
For those people that cannot do unattended treatments, certain ATs, massage therapists, depending on your scope and what state and what country, you have to be in the room. You cannot bill or you cannot do an unattended treatment. There's lots you can do still. Yes, the leaky gut has to run. So maybe in this case, you lend the CustomCare or rent the CustomCare for these clients to do all that stuff at home. That's the option for those people who can't do an unattended treatment, because yeah, sometimes things have to run. You don't want to be in the room having a client occupy a table for 3 hours running the PTSD protocol, for instance. So if you can't do it unattended in your clinic, give them the CustomCare to take home. And I feel like there's always monitoring though, even with the concussion protocol when I'm first putting it on people. Even if they fall asleep, I want to be in the room if they wake up, because if the pain, you just never know if the pain is going to increase somewhere, and you can be there to troubleshoot or at least gather information. Okay, what's running on the CustomCare? What could have caused the pain to increase? And then that time that you have just gives you so much information on how to build the antidote for it, or it at least helps bring you closer to what the driver was.
Yeah. And the thing I do if I have to leave, if I set up a patient unattended in a room, I leave the door open to the room
Right.
I'm in across the hall, the room they're in, and I'll just put them in a recliner. I have one kid with just thalamic pain from strokes, and it works better when he's in the clinic than it does at home for whatever reason. And so I just park him in the chair, recline him, leave him with his iPad, and leave the door open. So if something goes wrong, or I'll step out of the room I'm in and go back across the hall and check. So during the core, I say FSM patients take space. They don't necessarily take your time. So I used to see, I was always running behind, mind you, but I could see 2, 3 patients an hour.
Yeah.
And keep 3 rooms full 7 hours a day. So that was 21. I was routinely doing 17 to 18 patients a day instead of the 4 or 5 I do now. This is, oh, good. Glad you saw that. Do you want to take this one or?
You can go ahead. I think you're talking about Louise. So used to using the PO, I'm guessing that's the magnetic converter. I don't know.
Converter. Yeah.
The stickies, no brainer. I want to use wet towels. I'm confused. Clips on 2 different towels and towels not touching. Is it okay to attach both clips on one towel? Yes. So that, I'm wondering why that's not in the core.
There's pictures. There's pictures on every slide of where to put the towels.
Okay,
Red
so
and green clips,
yeah,
the one around the neck, and black and yellow clips on the other one, let's say down on the arm, low back to feet, neck to feet, red and green next to each other, because the water in the towel conducts. Thank God the water is good for something. And the challenge with the towels is they have to be hot, and the patient has to be because after an hour, the towels get cold and they get chilled. So there's that. And then positioning them where the nerve starts to where the nerve ends is the simplest part, or through the area. So back to front through the abdomen, if you're treating ovarian cysts or abdominal adhesions or whatever. And go back, you should still have the slides either available to you or saved on your computer. If you look through the slides, there's pictures on every single treatment slide about where to put the contacts. I promise. I've been
Yeah.
good. Okay. Do we want to take this first one?
Which first, the one that we just did, or is there more?
Suzanne.
Oh, I don't see it. Maybe
Yeah.
she.
Do you see it?
No.
Okay. For the West Nile virus and chronic lymphocytic leukemia client I had last week, I ran all of the virus frequencies, did see any difference. So it sounds like it should be, did not see any difference. I used the shoulder practicum on the affected side, did not see the results that I've previously with running this protocol with manual different terms of how the client responded to pain. There was some slight improved mobility that the client's OT observed the next morning. Client couldn't sense it was coming from FSM, even with still photographs, I guess. I could not get more abduction as we kept running into pain. Ideas, I stayed with the frequencies. Yeah, it's not 124, 93, 96. I'm not sure what the West Nile virus and the lymphocytic leukemia have to do with the shoulder pain, but if you can't get range of motion in 2 or 3 sessions, I go to torn and broken in the flat tendon, torn and broken in the round tendons, and torn and broken in the labrum in shoulders.
So if she used the shoulder practicum, I am assuming inflammation and scarring in the nerve has been done first,
Yes, I hope so.
because the shoulder is not going to move without treating the nerve.
But you always start with the nerve and the shoulder. The supine shoulder practicum that's a recipe. It is mechanically challenging to do. It is painful. And then you have to be able to switch from 40 to take the pain down to 13 to get it to move. And then when you run into trouble, it's usually because there's something mechanically deranged in the
Sure.
shoulder.
I think for shoulders, if you have the resource to listen to my frozen shoulder talk, there's a lot of other options there, especially the book that I had talked about a couple weeks ago, Dr. Codman's 1932 edition.
Codman's exercises.
Yeah, but that book is like my Romeo and Juliet. It's like Shakespeare, listening to the way he talks about the shoulder. It's just delicious. But it was his phrasing that really prompt me into thinking about fibrotic capsule. So sometimes the capsule is fibrotic or adhesive capsulitis, so you can really take a deep dive into the capsule. But going back and forth with the nerve, scarring and inflammation will help if there's pain involved, right? You have to get the client's pain down. That is the most important part of the equation. Then you can go after the scarring, what the limitations.
Which means that you actually have to work on the shoulder in the pain-free range.
Correct.
You can't take them into external rotation and abduction, and the pain level goes from a 3 or a 4 to a 9. You can't work it. You have to stay in the pain-free range and take what you get a millimeter or a centimeter at a time. And then they have home exercises. True frozen shoulder is not for sissies.
No.
Wall walking exercises, Codman's exercises, true frozen shoulder is work.
It is for
For
everybody.
the patient.
The practitioner, all of it. I feel frozen shoulder is absolutely a 2 or 3 device simultaneous treatment, 40 and 89 running in the background, because we have a ton of orthopedic testing, but the apprehension test for hypermobility that happens. I know we're talking about frozen shoulder, a shoulder that doesn't move. People that have had chronic dislocations and have scarring and pain, there's ranges that they will not go through. So even the frozen shoulder patient will stop before the limit is because they don't want to go any further. So running in 4089 in the background can be very helpful because you know you're going to increase range of motion, you're going to dissolve the adhesions, but their nervous system has been hijacked into thinking that movement, that range is going to elicit pain. 1489 running on the background while you're doing everything, in my opinion, has been very helpful.
And then I've started putting a separate machine on 40 and 396
Yeah.
as I'm getting the subscap loose, just so I don't have to keep having to go back to 40 and 390. Just run it all the time, and then it makes the scar tissue a lot easier. Oh my goodness. Okay, you're sitting down. Good. I'm not sure what's in the cup, but I had an email from somebody who said, I had an anterior dislocation. She's had two, the slap tear, those slap things. And so the procedure she had, I'd never heard of it, and I don't remember the name, but she said he took the coracoid off and put it at the front of the joint. And the rehab is just awful. It's not like the other two surgeries. It's been horrible. And he took the whole coracoid off? Finally, she clarified, no, he just took most of it off. He put the bone in the front of the joint capsule. And I'm not sure why anybody would do that to a shoulder. And I didn't know what to tell her. How do you stabilize the shoulder if the scapula has been disconnected from the rib cage? The coracoid comes under the collarbone and between the collarbone and the first and second rib, right? Yeah. And that it's this bony prominence that attaches to the scapula and actually attaches the scapula to the rib cage so that you have a shoulder. Okay, good. That's a good face.
I'm just trying to map that out in my brain and why I have an orthopedic friend that I am going to call 401 today and say, can you walk me through this? Because there's
a name for the surgery, and it didn't make any sense to me. I'd never heard of it before, and I've never heard of this procedure before. And you're the expert in this area, right? When it comes to shoulders, I'm a passenger on this bus. But okay, good. That was my response too.
I love shoulder mechanics. I love the coracoid process. I would never want to.
And the teres and the nerve artery and vein that go between the teres and the coracoid and
pec minor.
The pec minor to the coracoid and holds the whole thing to the ribs. And there's a nerve artery and vein that run under it. And then okay, good. That was just a scary email that I had.
I'm glad you didn't lead with that because I think I would have been gobsmacked for the rest of the podcast. I would have just been like,
yeah, I feel much better having talked about it. But it's like, what? And I'm glad you feel the same way because I don't understand.
I'm grateful for the
It's kind of like, for me, a surgeon. Yeah. Lacrojet. It had a weird name like that. That's probably it, Catherine. And it's okay. But it's similar to me as to why a surgeon would put titanium in one knee and cobalt, why anybody would use cobalt and chromium anyway, but why you would put a cobalt knee on the left and a titanium knee on the right. I just don't get it. So gives us all jobs.
I just Googled this very quickly, that later jet operation, surgical procedure used to treat recurrent shoulder dislocations typically caused by bone loss or fracture of the glenoid. I don't know yeah, but
And Catherine says it's a coracoid block, so they use a piece of the coracoid. They could get a piece of bone from someplace else,
this
but
is where my
that's
brain
what
kind
they
of went,
did.
like, why would you want to harvest the coracoid over harvesting from somewhere else
Wow.
or a synthetic? Because I've
Something.
heard there's also a procedure that when you have a Bankart lesion, right? So when the glenoid, when everything is, if you have instability and you've got that dent in the bone that doesn't repair, they do fill that. I'm typically used to hearing it filled with something synthetic and not harvesting the coracoid.
Yeah.
But interesting. I'm going to do some research about that later.
Well, we
I'm
don't see it too often.
Yeah. But in that case, there would be a bunch of 124 on the bone, 124 in the periosteum. Apparently, Leaf has a question about EyeCare. I didn't see it.
I
Um,
didn't either, Lee, but the story about the eye care is the same every time we have that story. Patients can use it at home. It works. JJ gave me one and it works. It's a very weak pulsed EMF. It has a 510K. It doesn't have a 510K because it's pulsed EMF, and people say that you don't need a 510K. And I just let them say that because it's not my area of expertise. So whether or not you need a 510K for pulsed EMF, I'm not sure. The Meg Healy has a 510K. So I'm not sure why our magnetic converter and the eye care are different. I did talk JJ into getting product liability insurance. So there's that. But because it doesn't have a 510K, you can't use it in your office or your malpractice. And it just, anything goes wrong. And sometimes you treat the patient on Monday. You tell the patient, get an eye care. He treats himself with an eye care on Monday night and Tuesday. And Wednesday, he has a heart attack or a stroke that are completely unrelated to what the eye care was using or what you did on Monday. And his son or his brother or his brother-in-law is a malpractice attorney. You got nothing. You're not even out on the skinny end of the branch. There is no branch. That is my concern. And from the like 1995, so for 30 years, avoiding malpractice, I actually read those flyers that come from my malpractice insurance company that say this guy got sued because of this. And this scenario is not unheard of. It is actually very common. You do something on Monday, and then the patient has X on Wednesday and decides to sue everybody, and you're on the list. And just imagine yourself in the witness stand saying, does that device have a 510K? No. Did you write a prescription for it? No, because it's not prescription. Did you recommend that the patient get it and use it at home as prescribed? Yes. Is that in your chart notes? No. Oops. Is that in your chart notes? Yes. Either way, you're screwed. Pardon my French, but that is my only problem with the eye care. It's the only problem. It's wonderful because it's inexpensive. It works for easy stuff. It works for even like we used it for spasticity when we were in Taiwan. And JJ didn't even have the magnetic pads. He just put his phone under my leg and the spasticity in my right hand went away. Okay, fine. And whether it works or not is not the issue. It's liability. And I've got too much to lose. I'm just really vigilant about it. Sorry, guys, but if you've got a practice, a house, a car, a savings account, a 401k, jewelry, anything, you You got to think it through. Essential tremor comes, intention tremor, essential tremor is the basal ganglia, intention tremor is the cerebellum. So essential tremor, 81 and 988. So increased secretions in the basal ganglia usually quiets an essential tremor, but then you have to do things to support dopamine. And I always forget what that is. Tyrosine, phenylalanine, if the patient tolerates. Designs for Health makes Dopa Boost. Review Roger Billica's neurotransmitter workshop, where he tells you what it takes to make dopamine. And then, yeah, that's about it. So there we go.
And it's 4:00. So there's that.
It's 3:59, but yeah, it's 4:00. Do we get through anything on your list? Do you still even have a list, or have you given it up?
Oh, I have a list. I always have a list, but that is the great thing about our podcast is that it organically grows and it's always relevant. And the list is there if we ever need it, as are the questions and all the things. So
Do you realize that in 2 weeks, we get to do the podcast from Phoenix together?
is it 2 weeks already? Pretty
I
close.
think so. I leave March 3rd, 3 weeks. Is it
Oh, yeah.
really 3 weeks?
I won't be there on the 5th. I will still be in California, but we'll have to figure out the 5th because you'll be teaching.
Yeah, we'll probably take off.
Yeah.
The 5th, yeah, we probably will be off on the 5th.
Yes.
And then, yeah, because that's the first day of the core.
So I will see you next week.
Yay.
We have 1 week off and then we get to do it in person, which is so
Yay.
fun.
This is exciting. Coming up. I'll see you next week.
Sounds great. Thanks, everybody.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.